Hello, everybody. Happy 2026. It's Paula Nutting, your musculoskeletal specialist, and welcome to the first of our Ask Me Anythings for this year. And I'm really excited to be going down a line that I think a lot of remedial therapists, massage therapists, lymph therapists, scar tissue therapists, we all kind of love nice, subtle, gentle, extra ways that we can help our clients and our patients when they have scarring of any descriptions. And I'm really, really excited because I had seen that 𝗀𝗵𝘁 had been around for the Massage and Myotherapy Association to assist with one of our conferences, and that she's written articles for us. And the second I saw that, I reached straight out to Emma to say, would you please come on board for one of my Ask Me Anythings, because I'm sure there'll be valuable information that you can offer, and that therapists who are out here listening to this can actually type in the chat box and we can answer in real time. So without any further ado, I would love Emma to come on board and introduce herself, and we'll do a quick info on beautiful 𝘁𝗵𝗀, and then we'll get started. So welcome aboard, Emma.
Hello, thank you so much for having me. It's a real delight, I must say. I just love the opportunity to tell more people about the importance of scars, because it was something that when I was, I probably spent the first 15, 20 years as a therapist not really thinking about them. My dog's having a quick rub in the background because she loves a massage too. Self-care, this is what it's all about. So I'm really excited. I'm going to be talking about the importance of scar tissue, but also lots of ways that you can think about different ways that we can stimulate scars.
Yeah, I'm so excited about this. We've had a few scar focused practitioners that we've interviewed and had the chance to chat to, and it's always so well received that it's great to think that we've got more. So as I said beforehand, before we get your not the elevator pitch, because I want to dig deep about your history, how you became where you've become, please don't forget, everybody, to type into the chat box. This will be recorded and be on the Your Musculoskeletal page for a while, the Chapman's Therapist page, and we'll send links out to Emma so that she can her page, and then it will be embedded into my my website, which means you'll be able to listen to the audio there as well. But before we keep going, I just want to do a quick plug to our one and only very supportive sponsors, 𝘁𝗵𝗀. They're an educational facility that started in Brisbane in Australia, and they are statewide, and they have been offering accelerated learning for Certificate 4, Diploma of Remedial, and then myotherapy for remedial massage and single event myotherapists who want to come through and learn from wherever you have been. So there's ways to integrate to go through, and then there's ways to just go, I want to be a myotherapist. What does that mean? I want you to look up the 𝘁𝗵𝗀. It's super easy to learn. They make every session fun, engaging, and memorable, so you actually remember stuff. And they do both online, face-to-face, and a combination. So if you're interested in becoming a myotherapist, a remedial massage therapist, please contact 𝘁𝗵𝗀 and get some more details from them. Anyway, Emma, unmute yourself, my lovely friend.
I will do.
Talking to another blonde. So please tell me your story, because I think that there's I love the fact that it seems to stem from a heart of charity, a heart of giving. So hey Libby, we've got Libby Jones O'Flaherty from Ireland who's there, and Sarah Williams from Gippsland. So I'm so excited about seeing both of you, and they've both been. I think Sarah has done your work, Emma. So
okay, amazing.
Tell us about you.
Yeah, so I mean, I trained like literally back in the dark ages in the 90s as a massage therapist, and I was always interested in working with people, particularly who had like pain conditions. I think that was one of the things I most enjoyed. And then what I found was after coming up to 20 years, I was really thinking, it felt a bit stuck. I felt like I was giving lots of great advice to my clients about things that they could do in between treatments. And I was still enjoying it, but I kind of felt like my kind of enthusiasm had lulled a little bit. And I was thinking, you know, I'm still quite young. What am I going to do moving forward? So it wasn't that I was specifically thinking, oh my God, right, what I want to do is get into scars at all, because actually the only scar I had myself was a tiny ganglion removal, which had never been an issue. Although a lot of people who come on my course say their scars haven't been an issue until they try some treatment and see the difference it makes. And yeah, and then so I wasn't quite sure where I wanted to go, but I knew I loved therapy. I knew I loved working with people and helping people. And I found a course. I first did 𝘀𝗵𝗵𝘁's scar work, and she is just absolutely inspirational. I literally I went up to, I'm from the south of England, just near London, and I went all the way up to Scotland to do the course with 𝗀𝗵𝗵𝘁. And then the same year I repeated it again with 𝘀𝗵𝗵𝘁, because I thought, you've got to meet the person who developed this. And in the car on the way back, I was posting into my Facebook group of my community saying, there was no case study element. You just did the course and went off and practiced. But I was like, I need to understand how this works. I need to understand, you know, so who wants free treatment? And by the time I got back home, like about 7 or 8 hours later, I already had about 20 people booked in, and I did about sort of 50 or 60 treatment just to get a better gauge of what to expect from treatments, what kind of results they can expect, how many treatments they might need, and all those kind of things, which was really helpful, but also kind of gave me really quick sort of hands-on experience. And from there, seeing the difference it makes and the kind of people that responded. So I ended up with quite a lot of people who'd been through, a few people who'd had burns, although not many, and then lots of people who'd had cancer. So that kind of started driving that pathway. And then quite a few kind of like women's health things, so cesareans and hysterectomies. And then I ended up thinking, this is so lovely, I will reach out to my local cancer charity, who offered things like Reiki and oncology massage, but didn't offer anything to do with scars. So I put on my big girl pants and I went in and I said, you need a scar clinic, and talked this lovely charity manager into letting me set up and run a scar clinic at that charity. And it's interesting to see now, because almost, well, not all, but almost all of the charities who have those kind of setups in the UK are now offering some person who does some volunteering with scars, because it's so integral. You can't really get through breast cancer without having a scar, and it's quite often a source of a problem. So that really kind of started driving me along that way. And Sharon asked me to teach, and I taught her course for a few years, and then we went into COVID, and things went horrible, didn't they, for all of us? Although luckily it seems quite a long time ago. But then I had people reaching out saying, I've got a problem with my scar, how can you help? And I was like, well, I can't do anything face to face. And all of the learning that I had had to that date was about the therapist bringing the intervention. The therapist touch was the one who was kind of doing it. And although you could try and kind of adapt some of the techniques for their use, it wasn't kind of in the ethos about self-management and things like that. So through lockdown, I wrote an online course about the importance of scar tissue and the importance of early care, because if you get the early care right, a bit like with any rehab, if you start off in the first few months kind of putting the right things in place for to support your body while you recover from an injury, but focused specifically around scar tissue management and scar tissue laydown. And then that launched after lockdown. And then it just kind of felt like, from what I used to teach to what I was now teaching, had gone into different pathways. And Sharon and I had a chat, and I ended up just then going, you know, doing my own thing.
Yeah. That's all right. It's dogs, kids, children, phones that's getting blocked out. No, we've done it all on this, honestly. It sounds like the most amazing story of that journey, all in helping, like the line from Sharon and Jan and through. So when you're talking about scars, are we looking at radiation differently to surgical, or is it kind of, and then burns to radiation? Because it's still a burn, but their distribution and how they actually are so different is quite, like, does it change your treatment?
Yeah, it certainly, once you get into sort of a linear surgical scar that's been cut by a surgeon is different from a traumatic scar. So when you go in for a planned surgery, there's something called Langer lines, which were discovered like hundreds of years ago, where they realized when they were working with cadavers that there are tensional lines across the body, a bit like we now know about 𝗁𝗵𝘁 fascial chains, but this was more about superficially on the skin. And so that has led surgeons to lead to making cuts in certain places. So, for example, historically, a cesarean would have been a vertical cut in order to keep the baby. And what we now know is there's this low transverse line. So you get a little nice small cut, generally speaking, if it all goes to plan, along the top of your pubic line. And one of the reasons they did that was about minimizing the damage to the muscles, the rectus abdominis, hernia risk and things like that, but also because there's more tension on that scar because of the way that it sits through our natural skin tension pathways. Those scars were more likely to become bigger, widespread, or keloid or hypertrophic. So if you have a surgery, you're already kind of at an advantage, because if that's how you got your scar, because somebody's thought about where to place those cuts to try and maximize the scar looking okay at the end, compared to somebody who maybe had a road traffic accident who ends up with a similar length linear scar, but something severed them, or they got impaled. Well, that won't be placed in any way that's strategically managed, and so therefore you've already got different tension lines on that scar.
Yeah.
Then the second part of that is like cancer, where you've also got chemotherapy changing literally the cellular nature of your tissues prior to surgery. Potentially, if you had preoperative chemo to try and reduce the tumor size, you could have chemo immediately afterwards, you could have radiotherapy, and they all bring different, like, they've all got a different consequence to the tissue.
Yeah, it's so interesting, because that is then dependent on how we approach our clinical rationale, our reasoning, and our application of the treatment. I'm curious, I'm just saying hello to Diane and Cheryl and Sandra, who have all popped in as well. So it's good to see some of the regulars here. A traumatic scar, is there any literature on the emotional distribution of whatever it's like? I'm a fascial person, so I'm always going to be looking at how the body responds in a protective mode. Within, like, we're going to take this baby out in a scheduled Caesar versus I've been impaled. Like, do you see stuff that's different, and how do you treat? Is there a difference in the way you treat?
Yeah, I think we've got to treat everyone as an individual, but I think what's important is, and sometimes is a really big thing that comes up as part of being a therapist who works with scars, is giving them space to revisit an event or a trauma. And when you start asking a person about what happened when they had their injury, whether that was a couple of months ago or whether that was decades ago, it very often will be something which, for whatever reason, that person has buried. Even a planned surgery can be, very traumatic for an individual. I had a lady who I saw for quite a long time who was going through a lot of counselling around having her hysterectomy. I mean, you're having your womb removed. How does that make you feel as a woman? And the whole of, for her, she had PTSD surrounding going into hospital and the trauma and the care that she had immediately afterwards. So you're navigating a bit like you might do if you work with kind of trauma-informed care. You're working carefully to bring on quite a powerful touch that also is asking for a sharing of information about something which, for the individual, could be, something that's hard to talk about. And often they don't realise quite how emotional they are, and how much emotions are tied in with scar tissue. But I think it's definitely part of what you do. But then there's also all this joy, all this. One of the things I absolutely love about scar tissue treatment is actually it's so lovely for therapists, because you get really quick wins compared to other sort of standard muscular issues, which can be slower to change. The difference with the way that scar tissue is, particularly if you're working with somebody in early healing, but not exclusive to that, is the way that you can sort of stimulate cellular change in that kind of tissue can be quite quick. It's not going to make it back to being a completely perfect tissue. It will still feel different from the surrounding tissue, but you can have somebody who's been numb for more than 10 years get sensation back in an area when you give a single treatment, which it blew me away when I became a therapist. And in my recent course, I've added in case studies. I wanted to kind of like up the level and also sort of have that kind of continuity. So when you walk out the door, how are you kind of like using this and so on. And I was, from a sort of course planner point of view, I was thinking, well, you've got to think, well, you can't expect somebody to, immediately have availability to see X number of treatments within X number of weeks. And if you start asking for too many treatments to be given, you're then actually really putting in a ridiculous timeline, and people think, well, I don't want to do that course because I won't actually finish for months and months and months. So for those reasons alone, I thought, well, okay, well, for it to be a case study, it needs to be more than a single treatment. So, okay, why don't we try 2 treatments for 2 patients? And I thought, they're not going to get a lot. They've only just done the course, but at least I can see what's their rationale. Why are they choosing certain techniques? Why are they omitting certain techniques? Are they noticing if there's anything, are they giving good home care advice? And so it was a good way for me to see what have people understood from the material, from the learning materials. And I introduced that last January, and I have been blown away, because the majority of case studies submitted, not all of them, and that's nothing to do with those people doing anything wrong in their case studies, but so many of them, they're like, this improved and that improved, and from range of movement to sleep quality, it might not be the thing that they thought would change, but we've already talked about the stress. So they didn't mention that they weren't sleeping very well, but since the treatment, they've been sleeping through, not getting up to go to the toilet because they've had a cesarean or hysterectomy scar. So that's improved sleep quality. We also do diaphragmatic techniques on a couple of the courses, because it's so integral, the breathing and the kind of scar tissue and recovery and trauma. But yeah, and so I think when I did my, my reflexology and massage case studies, I think what I achieved with the clients, not that there's anything wrong, and it's just, you should expect slower changes when you're working with, people with a tight psoas or, tight hamstrings, or who run every day. But that's because their body's still loading in that way that their lifestyle's built around, and that their the shape of their hips and their gait and all of those things. Whereas a scar is a result of an incident. An incident happened and your body created tissue around that incident, and you may have developed guarding patterns around it. Classic mastectomy, woman walks in like this, So but prior to that, she probably didn't. So in releasing the scar, getting the shoulder back comfy, that doesn't then regress back to this. And that's what's absolutely transformative. And so, it's so lovely, just from a therapist perspective, it's so lovely to think, wow, I've made that difference. And it's very likely that that's going to stick. And so
I was going to ask that question, but you've answered it just in there, because I was going to say, is it like musculoskeletal dysfunction that you have a treatment and then it'll regress after 6 weeks or because of patterning? But you've just answered that perfectly.
There are kind of parameters around that, just to be clear. So if somebody has radiotherapy and you can have a change of protein in your tissues, and so it can have a contractile, the tissue can be more contractile. So somebody with radiotherapy, they might regress over a number of weeks, or if they have like an inflammatory condition. So somebody who has there's something called capsular contracture you can get if you've had an implant, and you can make that feel a lot better, but it's an inflammatory condition through the fascial tissue, which would then tighten up again. Or it could be somebody's in chronic pain, they feel relief for a certain number of days and then it builds back in, and then you'd expect over a long course of treatments that you'd get bigger relief, lower constant pain if they're in constant pain, but you won't necessarily fully resolve an issue.
Okay, question. I know that part of the post-surgical symptoms of an anterior hip replacement is lateral thigh numbness, like it's really a sensational thing. So the scar, is it the scar? Is it the cutting of the nerve? Is it the open stretch of the scar? Is it what is it that creates that numbness? And can we offer techniques for the 𝗀𝗵𝘁 techniques or the 𝗀𝗵𝗵𝘁's techniques, or whatever, that our patients and clients could take home to apply to start getting some sensation back? Because it's like, I had a hip replacement in February last year, and it's one of those things that just always feels weird, and I fall back to going, oh, that is annoying. So is there a magic bullet for that?
Definitely. And, you know, like with anything, you know, if you've got an issue, seeing a skilled therapist, you know, whether it's a 𝗀𝗵𝗵𝘁 therapist or somebody who's done one of the restore courses, is definitely a good idea. And also that thought of not leaving it too late. I think a lot of people think something's going to resolve on its own, and then it might then require a couple more sessions because it's later on in healing than it would do at the beginning. Because at the beginning you've got, sorry, I'm going off piece. Why would somebody have numbness? Yes, you mentioned it all. Retraction, so the pressure of the tissue being pulled, could literally stretch and damage the nerves. That can remain inflamed, which can feel uncomfy. Also, the inflammation could be compressing on the nerve, stopping the nerve signaling pathway and disrupting everything. Ongoing inflammation, we know, imagine, you know, when you've been on a flight and your fingers are all puffy, they don't feel normal, do they? So anything that could reduce that inflammation is likely to have a positive effect. It could be that the nerve has been physically cut or damaged during surgery, in which case it could slowly regenerate potentially. If it's totally severed, I'd say it's fairly less likely. But if you'd had some kind of trauma to it, it can regrow, but nerves take up to 18 months to fully restore. So if you see, you know, that's the benefit of having this knowledge. If you see somebody who's after hip replacement, at what point should you be saying, well, to be honest, I don't really think that this is going to change at this stage? Or should you say, okay, well, it's likely that it could be these things, and therefore, you know, so if you've had 4 treatments and you're not getting any change in the sensation and it's 10 years old, it's more likely that you're not going to get any change in sensation because it's that old. You've given it quite a few scar tissue treatments and you've not got any change. If it's only 3 months old and you give 4 treatments, there could still be lots of underlying reasons to do with the more recent timing of the surgery which caused that. And then, you know, things that they can do at home. So I quite like, this is a new thing that's been invented in the UK. It comes with different shaped heads, but it's basically like a mini massager. So it's like a vibrational massager. So if I press the button, you might hear a very slight buzzing sound, and you work around the area. So a vibration brings a different stimulation. The oscillation through the tissues can help with the lymphatics and through hydration of the fascia. So you can tell someone to massage their own skull, but particularly massaging kind of around the back can be quite awkward if somebody, you know, had a sore. Just literally the fact that that's a bit longer can give a little bit more of a reach. And there's something about giving people a tool that can tend to increase engagement. Leave it by the bed, and when you go to bed, you see it and you think, oh yes, I must do my massage. And the other thing that I'm a massive advocate is cupping. So cupping, whether you go for like, they're all different shaped cups, but I like little silicone ones, and these they really they lift the tissue, so they help to increase the interstitial space, bring hydration through the fascia, but they also are creating some stretch to what is normally going to be fibrotic, stiffer tissue. And they're also, you should get quite a strong circulatory response. So you should get a little bit of erythema and it should go away. So the right cupping can also cause damage. The right level of cupping is really good. And if you're bringing the blood supply, you're supporting that nerve regeneration. So our body can only get better if it hasn't got lymphatic congestion. Like the tissue can't repair if there's lymphatic congestion, if you need the lymph to go in and out in order to help carry away the debris and support cellular regeneration, requires lymph flow, which is why you get the inflammatory response and an increased lymph flow after any surgery, but that can stagnate. So often after an orthopedic surgery, you can, in some cases, even get like really stiff fibrotic tissue, and that's to do with the lack of lymph flow. So things are sitting in that intersystem that is protein rich, that then becomes hard and fibrotic over time, and then will need to be softened and taken away. And things like cupping and vibrational tools, kinesiology tape, I love a bit of kinesiology tape. And then there's new inventions coming out, like there's this 6D tape. I don't think it's quite made it to Australia yet, but it comes with like tabs on it. So I've been giving this as homework for my patients. You stick a tab on, and they can pull the tab and create their own massage.
Oh, okay.
So you can do it making a fold in the tape, but it's the tension. There is a tensional difference with a self-made tab compared to a homemade tab. And even you can obviously cut holes in tape as well, but Pure Tape do a really nice punch tape. And so, Paula, if you can create something like this, just as a self-test. So if I couldn't get to someone and I wanted to bring on a little bit of stimulus, but this is like the most gentle version. So it will provide a neural stimulus, but it won't really, I haven't seen your skin condition, and I haven't seen your scar. So even if you had a thicker scar, I would be the least worried of all of the kind of types of tape to give you a punch tape to start with. And I'd say, put this over your tape, try it 3 or 4 days on. If I know you're in the summer there, so it might be that you need to change the tape more frequently, and then give your skin the rest for a day or two. Try that for a couple of weeks and then see if your sensations change, because different stimulus on the skin where we've got, and through that superficial fascia, could potentially just be what you need at the minute. Your body maybe needs that little nudge with some different stimulus. So those are some of the ideas that I might be saying to a client, but I'd bring on different stimulus for a treatment program, because people get bored. They'll do something for a couple of weeks and then they'll get bored, and you've got to say, I've got a new toy for you to play with.
Yeah, and that's exactly right. People have got an attention span of a gnat. So with the scar tissue restorative kind of therapy, are we looking at applying a specific scar tissue treatment and a specific lymphatic treatment, or are they all encompassed?
Yeah, so I don't teach a separate kind of, this is for lymph drainage, but a lot of people who do lymph drainage have said that they can see that there are crossovers with some of the technique moves, which happen naturally, because I only went on a lymphatic drainage course about 18 months ago, and I developed the techniques way before then. But I think naturally, and even through like your massage background, you're thinking about circulation, you're thinking about lymph flow, we're thinking about directional strokes. And also then doing a lymph drainage course, you've got these, for anyone who isn't, and I'm still nowhere near professing being an expert in lymph, but I then understood why some of my techniques were being really effective. So particularly what's really important is to bring in some skin stretch through, and not just directly on the scar, like around the scar as well. And then I've understood that there's little, so in the skin, the lymphatic vessels kind of come up, and there are these little things that sit, and they're called pre-collectors. And when you stretch the skin, they get opened and it helps the lymph go down in. So bringing in that, so why is that technique seeming to reduce lymph flow? And, if you've got somebody who's got a lymphatic condition, and you can watch literally their limb softening while you're working on the scar, so you're not draining the limb, you're working on the scar, but doing that is helping, because that's where the blockage is.
So could that tape, if you apply it and then add it like in a direction, that would mimic the same thing, or is it?
Well, just the fact that you're wearing it because you're functional and you're moving, you wearing it will change the tissue dynamics on a superficial level, which will change the bits of skin that are normally being stretched. So the kind of directional pull and stresses on the skin will change when you apply tape. You can go on a lymph training course with kinesio-tape, which if you don't want to do full length drainage, that was the first thing I did, and it's a really great bolt on to somebody who works with scars, is to understand how to leave somebody with some kinesio-tape to drain their limb, or to help, you know, post knee replacement, let's get that draining, they're often really congested. Scar tissue goes well with lots of things because rehabilitation takes multi-factors to get to the end result.
It's interesting. There was a fellow, Ron Alexander, or he's still alive, but Ron Alexander started functional fascial taping, and it was that tape that you were showing earlier, the 6D tape. It was almost like he had developed something that was going to be applying that, and then it's been developed over the top of, and he was doing things 15 or so years ago, but for dancers, ballet specific.
Oh, wow.
Then do taping of ankles and feet, etc., and getting them up and running again. So it's interesting. How much do you focus on? How much is it fascial? And how much do we go, it's not fascial, it's more superficial, it's more the skin?
I believe you can't separate them in my mind. I mean, the minute you're touching something, you're influencing the fascia. So I wouldn't, and if people say, oh, I'm just, you know, that. So, but I also, so for me, if you're working with the body and touching the body and you're working with scar tissue, you are working with fascia. How you describe it may change, you know, depending on if you're an occupational therapist in a hospital who's seeing someone immediately post-op to somebody who is a myofascial therapist who's really proficient in that language. And I think the other thing is I think as kind of holistic therapist or complementary therapist, however you want to say it, we underestimate what the skin's providing. The skin is our interaction with the world. The skin gives us information from its color, its temperature, the condition of it. So if your skin is dry and flaky, now I am talking about skin, I'm not talking about fascia. If your skin is dry and flaky around the scar, that to me is showing that your fascia is unhealthy. So if you're only talking about fascia, you're missing the huge organ that is our skin, which also is an indication of underlying health of the fascia. And I think, you know, so for example, for many years, I worked with a guy who'd just amazing. He was one of those, you know, life's not going to stop me. He was a guy from a place called sort of Birmingham. So he had this, we call him a brummie. So he's this kind of quite tough. And he'd had head and neck cancer, and he'd had 30 rounds of radiation, which isn't uncommon for somebody with head and neck cancer. But what that meant was that literally his tissue was stuck onto the structures of his neck. His SEM felt like a piece of wood. He had spasms on a daily basis. And from a skin perspective, obviously you could see that skin quality didn't look normal, more dimpling, loss of hair in all of the areas where the radiotherapy had been, because that damage blasts and injures that tissue to such a degree that your hair follicles don't recover. Obviously numbness is another thing. And he came to me for some treatments over sort of about almost a year period. We got him out of the spasm. We treat all the major symptoms left, but he was so passionate about how much it had helped him. He came along to many courses for me to use him as a model. And then we had COVID and I didn't see him for a while. And he came back, and I said to him when I was demonstrating on him, I said, oh my God, you've got to start shaving, because he'd had hair recovery, which is, as far as I'm aware, pretty unheard of after that treatment. So it doesn't have, you know, some of the changes that you're delivering are happening immediately, but otherwise if we get that tissue glide improved and then allow the underlying structures, the fascia, the circulation that comes up to the surface of the skin, just the nerves, all those things, that then redevelopment and rehabilitation within the body can take a long time. But it was just, and he was like, oh my God, I didn't even notice that. Yeah, you're right. I've got stubble here. It's a clean shave. And it just, having still been now only, it's 11 years this year since I did my first course in scar tissue. And I still feel now I'm seeing what the long-term effect of treatments can be, which wasn't very clear initially because there wasn't really many documented case examples. There wasn't really there was no clarity on kind of treatment planning or what can they expect after this and what can they expect after this, because that, it was just Sharon doing her work. And I think now, building up that clinical knowledge, presenting case studies, getting people to sort of document what they're doing is a way of us actually, as a body of people interested in scars, making sure that we can be clear on what potential outcomes we can bring to patients, which can be, really incredible.
Yeah, that's amazing. We've got one of the people who is listening from Geelong, I think. Sarah said, "I am a Brummy," but
I remember you. Now I've got the right chat up. I know exactly who you are, Sarah.
So what I might do is I might do a quick plug over to Q Academy, and then, if it's possible, if we can think of some practical tips that we can start offering some of
this. And should I just say, because although I'm here in the UK, we've got courses over in Australia for anyone who already wants to start looking or be interested. So we've got courses this year.
We'll get that. I'll get all the dates, etc. But what we'll do is we'll toss over to Q Academy, and then we'll be back in a minute or two.
No problem.
My name is 𝗁𝗵𝘁. I studied Cert 4 massage in 2014 and then went on to remedial in 2015. I was working in ASICs. I was retail, Lorna Jane. The real reason why I went and studied was my daughter was, she's been quite sick for about 7 years on and off. She's had a couple of chronic conditions. So I found it hard working in a job and having to leave because my children are sick or I've got to go to hospital or there's just so many things going on. For me, I needed another option. I've been set up for about 8 years now, working from home. Having a home business has been like such a blessing to my life. I don't think I could have done what I've done somewhere else just with my own circumstances. My life's very busy. I've got 3 kids. And this year has been a little bit different again because now I've got 3 kids playing sports every afternoon. So I do try, if I can, work in between school hours. I feel like you can make it work to your advantage. So you can either work as hard as you want and be stressed and all the things, or you can make it flexible.
And that's just the many, many success stories from Q Academy. So they're brilliant. Have we got some ideas on how we can help some of the people who've got scars or in self-care? And also I noticed that you were talking about it's not only the massage work, but it's also topical products that I'm guessing that you have.
Yes, this is my favourite cream, 𝗷𝗪𝗿, and over there it's sold by Australian Medical Supplies. 40% aloe, no parabens and SLSs and horrible things like that. But scars need 3 things: an occlusive hiver mat, and they work together. And I'm trying now, humectant. That's the one I always forget because it's a horrible word to remember. And basically, they basically, one of them is stopping the evaporation from the top of the skin, and the other one is actually like delivering moisture, and the third is actually pulling moisture from the surrounding tissues because you've got more water loss occurring at the scar site itself. So a lot of the time, if somebody's got pain in early healing, then it could just be that their inflammation at the scar site is being driven by the water loss and the skin irritability. So it can be like just really helpful if somebody's in a lot of discomfort on a daily basis to get them on the right cream. And it's, you know, you can just go to the pharmacy and buy some cheap white stuff, but actually having the right properties in there feeds the skin with the right things. And then there's silicone sheets, and there's a whole kind of, you know, which product is the right product and how to choose products. Oils are also really good. Over here we've got the 𝗀𝗃𝗀𝗃 oil, which is a really nice natural oil. This only got 6 ingredients in it. You use it intensively for 2 weeks on your scar, and it really helps deliver the kind of nutrients that is required from skin in those early healing weeks. It's really great, lovely for scars.
Yes, that's when, like, if you come out of having any kind of surgical procedure, whether it's visceral or skeletal, you would apply these on after the infection control period of time?
Yeah, so people get a bit muddled with scars and wounds. So I'm only ever talking about when the scabs have come off, but the minute you have new skin, that is then a scar, and it's obviously going to be most requiring some topical support quite early on. But you've got to be careful. It's cream's great for your first start, so I generally say start with cream. But if you go silicone as a sheet, which is a bit like a big clear plaster, you could then potentially, particularly if you use it really early on, if somebody was at risk of infection, which they are most in the first 12 weeks, but within the first 12 weeks, you should imagine that the skin has recovered and the scabs have fallen off. So just, you know, I wouldn't want somebody who hadn't done any extra scar training recommending silicone sheets if they don't know what they're talking about. Because if you do it too early, you could, there is a potential infection risk, so there'd need to be some other parameters around it.
Okay. Sarah was just saying she's doing your advanced scar training this year after doing the course with you in Melbourne. I'm guessing that was last year. Can't recommend highly enough the training Emma puts in with. Is incredibly well put together and delivered. So there you go. If you're thinking about doing a course in scar restoration work, which I think, what do you call it? Restore therapy.
Ironically, it was my name before I got into scars. It was what I called my business, was Restore Therapy. And then I was like, oh, do I have to change it? And I was like, no, it's perfect.
Yeah, well, how long, maybe if we can get, if there's any chance you could show us some practical tips. I don't know if it's possible or not. And B, how long are the courses? You know, how often can I just look up and download the online, or is there a face-to-face component? How do they work?
Yes, I've got an online only advanced theory, which is it definitely is advanced. Like, you don't have to know anything beforehand, but it really is a very comprehensive course. I'm a bit dyslexic, so I'd never write a book. So that is my kind of book, and it's short video lessons with interactive quiz questions. And because I did it in lockdown, I managed to secure some amazing global experts in wound care and scar research and things, which was really kind of made my year livable. And then but a lot of the courses that I teach have a mixture of some basic theory online, followed by practical in-person days, and then you have a case study component. So it's more of a kind of drip feeding you information. I think most of us aren't very good when all of the theory and all of the practical is delivered in person, because it's a lot to take on. So we do sort of bite-sized chunks of theory in the month before you attend, and then we, you know, kind of skirt through some of those conversations. How is that relevant to the practical when you're in class? And the courses there's 3 courses. There's a practitioner course which covers all different kinds of scars, from burns to you know, bunion surgery to cosmetic surgery, and that's really about what are the ways in which we can treat scars. So in terms of kind of broad skills only for scar tissue and, you know, surgery and trauma injury, that delivers the biggest punch, because it's like, well, you could do cupping, you could do kinesiology tape, you could do massage, which is the major element of it, and these are the massage techniques. And then how would you recommend topical products, and how do you create a home care plan? So that's all on that course. But you can also jump just directly onto more specific courses. So there's a cesarean scar specialist course, which is going out to Australia for the second time in May. And this one is literally abdominal and cesarean scar massage, together with some hip and glute work and diaphragmatic work, because there's a real connection between diaphragm and pelvic floor, and then diastasis assessment, because you shouldn't be really working with postnatal recovery if you don't understand how to check for abdominal separation. I've got some great techniques for deep abdominal release for people with diastasis to take some of that pressure off, to support them with their recovery. And then the oncology specific course, it's looking at very specific things that people have after cancer surgery. So radiotherapy, fibrosis, how does chemotherapy and radiotherapy affect the tissues? What can you expect in terms of results that are different from that patient cohort? And then also there's lots of people who have breast cancer who end up with cording, which is like a thick cord down the arm, which restricts arm movement. And so there's loads of shoulder techniques and working in the axilla techniques, which are also good for people who just have stiff shoulders, but they are amazing, and they can get phenomenal results for people who struggle after breast cancer with shoulder mobility.
And they're really gentle, like the old days where you'd have to beat up the skin. Now that, I interviewed 𝗀𝗵𝗄𝗃, which was amazing, and looked at some of the techniques from Sharon, and it's just so gentle. Is it?
Yeah, I think my method is, so I think on the spectrum of kind of like teaching practices, that's lighter than I am, and there's a bit more. I introduce much more dynamic movement. So as well as having, so some of my touch is really light and soft, but there's quite a bit of kind of dynamic stretching. So let's say somebody came in and they'd had like a carpal tunnel, and when they go into certain movements, that's pulling on the scar. So we do a protect and stretch. So we lock the scar and do a stretching movement, or we can do scar stretch where we're actually stretching the scar with the movement. So what happens if we encourage the glide of the scar, if we resist the glide of the scar? So we're looking at different ways in which we can play with the tensional forces, and that informs the body in a different way. So I use that a lot, particularly, I just talked about cording. So if I go to that as an example, if somebody lifts their arm to a certain point and then they get a pain, but we block above that, they're going to get the pain at a different point. It can help retrain that pain messaging, because the body starts saying, well, I don't go there because it hurts, and this is where it hurts. And the minute you change the end point restriction feel, the body goes, oh, well, actually, I can get there. And before you know it, like literally within 5 minutes, you can have increased range of movement in the arm by 10 degrees, 20 degrees. So it's what I do now is not Sharon Wheeler scar work. It's looking at sort of multi, but I'd still recommend anyone to do that course. It's a great course. They're just different. So I'm not quite as light. There's a bit more focus on different techniques being applied for different considerations. So what's the problem? Which are the techniques from the repertoire which are going to help that problem, and how do you put them together?
Yeah, no, and I love that. It's kind of the movement facilitation is all about how the nervous system works anyway. So we're kind of linking the two together, and that's more like my jam is movement facilitated techniques. So like I would lean towards the understanding of that more than the understanding of static treatment. Sarah said diaphragmatic pinning I use on many client scars or not. I'm not quite sure what it means.
So where you get, so we can lock on the tissue and get some movements and come in and do work around the diaphragm. Because I think, the whole point is the way I'm often talking to students when you've got somebody with a scar is we've got to be realistic. Even if that person, Paula, even if your hip had the best surgeon and the scar healed as beautifully as possible, that's never going to be what you had before you needed hip replacement, but the body is great at being able to work around and compensate, and we need to think about which are safe compensations which aren't going to lead to then another problem because of compensation, and how can we tap into those. So for example, if the scar has got a limited stretch and it's literally because tissue's been removed, that's why they are finding pain on end of range. We know look at us, we get pregnant, we get fatter, we get thinner. Our skin and our fascia are dynamic, and we just need to tap into how to get that, how to allow the body to stretch around the scar in a way that isn't triggering pain. And so those are the kind of concepts that we're working with. Where's the pain coming from? Can we take the pain out of the equation and tap into the body's own mechanisms for encouraging recovery when you have a loss of tissue mobility?
Yeah, wow. Two things. One, I'm hoping that Sophia will put in the little ticker tape down there, not my stuff, but add actually your website details, maybe some links to courses and stuff that you've got coming up, because I suddenly went, oh, that's all about there, and restore therapy. With
no, it did come up earlier, and she's brilliant, isn't she? I think I need somebody like her working with me.
I need a little bit more data if we can get there. Tell me about the Invictus Games. How long have you been doing?
Oh, that was amazing. Yeah, so I got in touch with a smaller charity which worked with limbless veterans, and happened to find somebody who was actually one of our amazing athletes, who is an amputee, a bilateral amputee, leg amputee, who's done incredible things. And we started off by just giving him a treat. Well, it wasn't even me. I found a therapist who'd done some scar tissue work and got him a treatment. And then he kind of like put a nod into the person who'd done a lot of his sort of rehab training, kind of like, personal training and group training for him through the Invictus. And we were allowed to just turn up and be pitch side and give treatments. The first year it was just 3 of us. And then that's kind of grown, and we did that then for 4 years. We went to the biggest disability event that UK has ever had, and had hundreds of treatments that we gave. And the data scores on, so we asked them, what's your pain level coming in, what's your pain level going out, and we got, we went from, I think it was an average of 6 out of 10 coming in, and an average of 2 out of 10 walking out of treatment in a single treatment on the pitch side in the middle of a stressful event for somebody and that lots of personal best with the games that they did. And then, and that stopped we did 1 year after COVID. And then recently I've been working with a burns charity. So on Saturday, I've got loads of bags in the corner. Yeah, we're doing a burn survivor day. So it's an opportunity for therapists who've completed training to come and give massage to burn survivors, and there'll be some of the teaching team there. And for burn survivors, some of them had burns this year, but others were burnt in childhood, and they're now in their 50s and 60s. And what's around now isn't what's around then. So together with the charity, we hired an osteopathy school. There's going to be coffee and cake, massages going on, talks on skin camouflage. It's the 4th time I'm doing an event with them, and the feedback from the burn survivors has been amazing. But for me as well, the feedback from the therapists, to have the opportunity to work with these kind of individuals who might have lost all of their digits and have 80% burns. If that walks into your clinic, that's quite scary. And so kind of like a bit of hand holding, a bit of and it was the same with the Invictus. People don't often get to work with amputees, so being able to facilitate opportunities that benefit 2 communities that I'm passionate about is just amazing.
It's incredible, isn't it? And all what I'm hearing, and what I'm hoping is for take home for anyone who's listening, is that charting case studies, just going into a VAS score, anything that you can do, reproducible information, is going to improve the quality of how we can get our information out into the allopathic world, how we can make our voice heard in our treatment modalities, because I don't know what it's like over in the UK or the USA, etc., but it's quite difficult to have credibility around massage in what it looks like, because there's no Cochrane peer review. We don't have the stuff that the physiotherapists require as a minimum. So they go, there's no hard research that proves that doing this technique on the myofascia is making any difference. So therefore, it doesn't. And that
I think because of within oncology, I've managed to make massive headways. I've even trained a whole team at 𝗀𝗵𝘄𝗿 Hospital. They booked an exclusive course down there, the physios. And in the UK, I think we've had most of the major cancer centres, and I think round about, we have healthcare trusts. More than 50% of the healthcare trusts have sent their staff to us. And I got invited to speak at the Association of Breast Cancer Surgeons annual conference to breast cancer surgeons. And of course, as me, a massage therapist standing up in front of breast surgeons, I was absolutely terrified. And the reaction, I was there with, I had a couple of my teaching team for moral support, and they said when I stopped speaking, they left the auditorium because they could, they'd offered us a stand on the conference floor, and they said we could already see the minute you stopped talking, people were making a beeline, and by the time they got to the stand, there was a queue of people, and there were still other talks after me. And the thing is that it's the one thing I would say. The medical people are telling people to massage their scars in a way that they're not telling people to massage their sore backs or sore legs. So yes, it is a massive in to healthcare systems and to understand. So for me, the transformation of being a massage therapist, training occupational therapists, training physios, training clinical nurse specialists, like those are people who also join my courses. Midwives, you know, and it makes midwives based in hospitals, you know, it makes for a really amazing learning environment, because you've got somebody who's like a fascial therapist who works in a little clinic around the corner, to somebody who's like the lead physio who sees people just before they have radiotherapy and is struggling to get them into their position that they need for the radiotherapy. And so the discussions that go on in class with this kind of skills sharing is phenomenal, and it's been great to see that actually there has in this instance, because of its niche application, been a break into, but I still think we need more case studies and you know, report writing and bigger research and things. But otherwise we just go down the machine route, and when I go to some SCAR conference, it's just all about the lasers, because they can just replicate the same technique again and again.
Yeah, and it doesn't add for that. I mean, the only thing that you can't add into a case study's outcomes is the trust and the, you know, that connection. And that connection is so deep and so powerful. You have somebody who you know, how many times do you have patients or clients that come to you and say, I've had back pain, but the second I woke up this morning, I know I was coming to see you. Settle down. And it's that absolute beautiful placebo is not a dirty word. It's the body innately going into a repair phase because of the trust with their therapist. So, you know, aside from that, but how the heck you put that into a measurement scale, I have no idea. Tell me where people can go for more information, Emma, and what would you say for a first-time person who's interested? What should they look at first on your website?
I think if you're someone who easily feels a bit overwhelmed, actually the cesarean course is maybe a nice one to start with, because it's so specific. You get everything you need to know about what happens in surgery, what happens afterwards, and you get like a kind of really a kind of core skills of how to build up a routine. Whereas the other courses, there are so many, well, it could be this, and you could be working on this part of the body, and you could be working on that part of the body. So if you're a person who's like already feeling really confident in your kind of like assessments and things like that, then either the practitioner or the oncology scar specialist are good courses to go to. I'd say the oncology, if you work more with people who've had cancer surgery, or that's an area that you want to get into, it blends beautifully with lots of different kinds of modalities, and it's designed to be integrated with your own skills. And the scar therapy practitioner, just if you like using different things, if you want to have a try of tape, if you want to try cupping, if you want to think, oh, well, I do see a lot of orthopedic surgeries. If you work in, you know, kind of like sports or athletics, that would probably be the better course for you. but all of them, you'll come away with something. And although that, you know, it's got a certain name to how I've clustered things, there's a massive crossover. I'd use techniques from the scar therapy course on both other courses, but because I had people booking in from hospitals, rather than making it, you have to do this before you do this, before you do this, I had to make it that if you work in oncology and you're coming from a cancer hospital, you don't have to pay for 3 courses before you get onto that specific stuff for your patient benefit. So that's the reason that the courses are just jump on what you want, give it a go, and then come back and do another one. And then you know, if you love to get to the nitty gritty of the why and the what's the kind of reasoning behind and what do I need to think about for different injuries, or you're just struggling to get to an in-person course, then the Understanding Scars is the one to go for. Just really comprehensive, works through from skin and fascia through to kind of like orthopedic trauma, and we look at kind of common injuries that affect predominantly those systems of the body, as well as looking at the overall impact of scar tissue.
Wow, that's amazing. So I just put one last point, saying that Toowoomba has a major oncology massage. Yeah. So that's brilliant. And it's 2 hours up the road from me, or not even that. Oh, I keep getting yeah, I'm quite close to there. It's just on the hour, or just over the hour. And Emma, it has been an absolute pleasure. Thank you, everybody, for showing up. Rosemary and Jack and Sophia and Libby and Sarah and who else is it? Sandra, Jarell, and Diane. It's been a long time since I've seen some of these little names here. So thank you so much. I'm hoping that we're going to be getting a few more people that will come in and listen to this recording, and then put down some, maybe if they've got some actual questions. If we do have questions, are you happy if, like, you might see something in there, just tag Emma in the question in the chat area, and if she can help, I'm sure she'd be delighted to. It's just even put Emma might actually put down the 2 products or the 3 products in there that we can access. But that'd be great. Emma, thank you so much for sharing of your knowledge and time. It's been an absolute pleasure.
No problem.
Hopefully we're going to get a chance to see some other big hitters this year. And if you've got any people that you'd like me to try to get to interview, then just put their names down in the link as well, and I'll see what I can do. But next one up, I think, is I'm trying to track down Carol Davis. So we'll see how we go with that. Anyway, thank you, everybody, for coming. I'll give you some info on the next date as soon as I know as well. But enjoy the rest of your day or your night, and I'll see you around in social land.